Hello, everyone. This is hashtag CRA Arthritis. I'm Kelly Lenvoy. Happy that you could join us today. Today, we're going to be looking at an interesting workshop, and it is being co-led by Dr. Luke Chen. He's a hematologist and professor of medicine at Dalhousie University, an affiliate professor at the University of British Columbia. His clinical and research interests are in rare inflammatory diseases, including IgG4-related disease, Still's disease, cytokine storm syndromes, and as many of you are aware, ACE is based in Vancouver, and I'm also very proud to say Dr. Chen is an honorary UBC rheumatologist after spending almost 2 decades here in British Columbia leading research efforts. Dr. Chen, welcome to the show.
Thank you so much, Kelly. It's a pleasure to be here.
So this is sort of a home and home. I'm here in Vancouver, heading out to Halifax, where you now reside and work. And the workshop you're going to be leading at the Halifax conference is titled Unexplained Lymphadenopathy, Recognizing Rare Disease Patterns in the Rheumatology Clinic. Dr. Chen, many people are not going to be familiar with the term lymphadenopathy. Maybe we can start by you providing a definition and why can it sometimes be a sign of an underlying inflammatory disease?
That's a great question, Kelly. I mean, first, let me say I'm very excited about this workshop. It is really a home and home. I'm delighted to present with Dr. Alex Legg, rheumatologist here in Halifax, who I've been working with closely, and really happy to see a lot of my colleagues from the West Coast again, and definitely that plaque that says I'm an honorary UBC rheumatologist is my favorite thing on my awards shelf, and so I look forward to reconnecting with my rheumatology friends. Lymphadenopathy is definitely something that rheumatologists and hematologists share in common as a tricky problem. It simply means a swollen lymph node. Lymph nodes are present throughout our body, but particularly in the drainage basins around our neck, armpits, groin. And because so many immune cells traffic through there, they become swollen in many diseases where there's immune dysregulation or inflammation or a malignant cancerous process, and so lymphadenopathy simply means swollen lymph nodes, and it's often a sign that there's an inflammatory or malignant or infectious process in the body.
So in your workshop, you're going to look at cases where the cause of lymph node swelling is unclear. Why can these cases, sorry, be so challenging to diagnosis even for specialists?
Yeah, because it's really because there are so many different things that can cause lymphadenopathy, ranging from autoimmune and autoinflammatory diseases that would be more in the realm of rheumatologists to malignant lymphomas that would be something that hematologists would deal with, to metastatic cancer that perhaps a medical or radiation oncologist would have to deal with, or an infectious process that an internist or infectious disease doctor would have to deal with. And um, the focus of our workshop will be really the difficult or challenging case of lymphadenopathy, because when you have a swollen lymph node, once you get a biopsy, often the biopsy tells you what the problem is. But sometimes, I think as rheumatologists and hematologists, we've all had difficult cases where the patient's already had the usual examinations, including a biopsy, and we still don't know what their problem is. So that's really what the focus of this workshop will be.
You're going to be explaining some of the key clues that help doctors distinguish between rare conditions like Castleman disease, IgG4 related disease, and adult onset Still's disease. Um, Obviously, a very specialized area. What are some of these clues?
Right. So I think the biggest thing is that we have to be familiar with some of these conditions that cause lymphadenopathy and yet are not always immediately evident on biopsy.
Right.
In fact, a common theme of these conditions is that they require clinical pathologic correlation. And what I mean by that is there are a lot of diseases where you the surgeon goes in and takes out the lymph node and sends it to the lab, and the pathologist tells us exactly what the problem is. Aha, this is Hodgkin lymphoma, or this is tuberculosis, or this is metastatic lung cancer to the lymph node. That's diagnostically, that's quite easy because the surgeon does the work, scoops out the lymph node, and the pathologist tells us the answer. But what about those cases where a patient has fevers, inflammatory problems, maybe inflammatory arthritis, other issues, and we scoop out a lymph node, and the pathology report is just, oh, there's a lot of reactive changes here. It's non-diagnostic. What do we do then? And so uh, a big part of working a patient like that up is recognizing that there are some conditions that classically present like that. For example, many patients with Castleman disease, unless you talk to the pathologist and tell them that Castleman disease is on the differential diagnosis, the pathologist may just interpret those findings as reactive. But if you ask them to go back and specifically look for features of Castleman's and comment on those, they can tell you, oh, in the right clinical context, this is consistent with Castleman disease. Or likewise, in Still's disease, the classic finding is what we call dermatopathic lymphadenopathy. So in Still's disease, many patients have an inflammatory skin rash, and the lymph nodes may be swollen, but they're not swollen because of a problem with the lymph node itself. It's a response to the inflammation in the body and more specifically, the inflammation in the overlying skin. And it can be mistaken for histiocyte disorder because it's very common that in Still's disease there are increased number of S100 positive histiocytes, and that can mimic histiocyte disorders like Langerhans cell histiocytosis or Rosai-Dorfman-Daytum disease. Or
Hmm.
maybe it actually is Rosai-Dorfman-Daytum disease because that can present with S100 positive histiocytes and extensive skin inflammation. So which is it? Well, you have to start by having a basic awareness of what those entities are and how they can present before you can really delve into diagnosing them. And the second key message that I want to present at the workshop is that there are certain blood tests that can be very helpful. Sometimes when we have a challenging patient like this, just sending off tests like IgG subclasses, ACE level, EBV viral load, those things can just help decrease the cognitive load a little bit when we're dealing with a differential diagnosis that includes a lot of very rare entities.
The final question, and I guess this is a key message for patients who are going through testing for unexplained symptoms like a swollen lymph node. What can they expect from the diagnosis process, and how can they advocate for themselves along the way with their healthcare team?
Um, I think the key thing is to, establish a partnership with your physician, and make sure that you understand the tests that you're going through and understand that some of those tests may not be comfortable. I know sometimes when I tell a person that we really need to send you to a surgeon to get an excisional lymph node biopsy, which may mean undergoing general anesthetic, or in some cases just going to diagnostic radiology to get a core biopsy. A lot of patients will tell me, "Oh, do I really need that?" And
Mm.
most of the time, if we have unexplained lymphadenopathy in hematology, we have a saying that lumps belong in the lab. That if you've got an unusual lump in your body, the best thing is to take it out, or at least take out a good portion of it, so we can take it to the lab and figure out what it is. And sometimes you get lucky. If there's a case of obvious IgG4 related disease or something like that, you may not always need a biopsy, or you may already have a biopsy sitting in the lab that you can use. But most of the time, my motto is that lumps belong in the lab. Um, and secondly, I know that with Google and artificial intelligence, there's a lot more information at everyone's fingertips, and that can be a good thing and it can be a bad thing. I've had many of my patients who have been sent down a very anxious pathway because of something that they've read on the internet that actually isn't really relevant to their situation. So I think it's a good thing to inform yourself. I think it's really important to stick to reliable sources. Often with the AI generated answers, you have no idea where they got the answers. So you're better off sticking to reputable sources like, the Mayo Clinic or Leukemia and Lymphoma Society, or reputable societies giving good information. And then secondly, if you find something that you think is useful, I just bring it to your doctor. It's sometimes I have people walk into my office and tell me, well, I read on the internet somewhere that you should give me this medication or you should do this test. And well, that's not really helpful. Where did you read it, right? And why do you think that applies to you? So I think, specifics and the reliability of sources are important, but I do think it's important for patients and loved ones to be informed and to educate themselves as much as possible.
Reminder to our audience today, we will have some of those reliable, trusted references at the end of this episode if they want to learn more. That wraps up the interview. We want to thank you.
Thank you so much. It's a pleasure to be here, and I really look forward to seeing everyone.
And thank you to our audience for joining us for another episode of hashtag CRA Arthritis. We look forward to seeing you again soon. Bye for now.